So let me start off by welcoming you all. My name is Harun Saluji. I'm a pediatrician based at Wits University, but also a member of the South African Child Health Priorities Association Executive. We have three wonderful speakers for this afternoon session, and the theme is all about austerity. Now, I'm sure many people are still, if you had to define austerity very clearly, you may come up with very answers. So I actually went to the dictionary to see what exactly is austerity. And I think what I've learned is that it's a political economic policies. And the whole purpose of austerity is to try and reduce government budgets. And government does this by two main means. It either increases our taxes or it reduces spending cuts, or it might do both. And I think in South Africa, we've mostly gone for the spending cut approach. I've also learned that the word austerity comes from the Latin term austerus, which means severe or harsh. So essentially what austerity involves is harsh, rough, and severely simple conditions. So why do government implement austerity? And really it's when governments face challenges in borrowing or meeting existing loan obligations. And we know South Africa has been in that situation like many governments around the world. So proponents of austerity really argue that these measures demonstrate fiscal discipline to creditors and the big international credit agencies. And so that allows us, the government, to borrow at an easier and a cheaper rate. But the problem is that many of these austerity measures have consequences. And for children, we'll hear a lot about it, but it may be direct or indirect. And indirect really means it affects everybody. So we know macroeconomic policies favoring austerity increase unemployment rates in the short term. They increase poverty rates, and that clearly will influence children. But I think what's of more concern for us is the direct effects on social spending, health in particular, reducing access, reducing quality of care, but also access to education, to social policy. And so that's the reason we're having this session, because we know there's austerity and we're beginning to see these effects. So in summary, austerity represents a trade-off between budget deficits and potential short-term economic and social consequences. And so today we've got three speakers, and what we're really going to do is we're going to start off by understanding what are some of these austerity measures, where are the budget cuts happening, and what does it mean for children's health and well-being. We'll then go on to look at, so what can we do about this? Can we actually influence government to do something about it? They've made a decision, but if it's affecting children's health and well-being, what do we do about it? And then finally, we'll look at, in real time, as these events are happening, how can we measure the effects of austerity so that at least our advocacy efforts are based on some evidence and facts? Okay, so that's a little bit of a background. So let's immediately get into our sessions. So our first speaker is Matshidiso Lencoana. I hope I got your surname right, Matshidiso. But she's from Section 27, and she's a budget policy analyst and researcher at Section 27. And she's been a strong advocate for fiscal policy and interventions that make sure that the constitutional rights to things like basic education and access to health continue, particularly also in the background of many of the climate change effects that we see. And her particular focus is on gender responsive budgeting and using these budget policies to ensure these socioeconomic rights are retained. She serves on various committees, but I think what's notable is she's on the steering committee of the Budget Justice Coalition and Imali Yethu. She's also forms part of the Fiscal Openness Accelerator Advisory Group for the National Treasury. So she knows a lot of what Treasury is doing to us. She's got a master's in international development, which she got from the University of Sussex in the UK. She's also got a Bachelor of Commerce from Wits, and she's a Mandela Washington 2003 Fellow. So Matshidiso, welcome, and I invite you now to do your presentation. What you're going to tell us is how the healthcare budget has been cut in real terms, and are there opportunities for us to do something about it? Thank you. Please go ahead, Matshidiso.
Thank you so much for that introduction. As I share, I'm about to share my screen. I just want to make it presentation mode. Yeah, okay. So I just want to start off by saying that I'm really honored to be here, to be in conversation with public health professionals. I'm assuming that most people in the audience are public healthcare practitioners, because the work that we do in terms of pursuing economic justice in in healthcare has just highlighted to me just how it really is the people, the healthcare practitioners, who are keeping the system somewhat functional. And also, I grew up, like, for most of my life, I've been a beneficiary of public healthcare. So I know that it's just so eye-opening to see that you really are doing a lot with a little. And that definitely needs to change, which is why I'm so passionate about this. So I've just actually jumped into it to talk about austerity, which Haroon has perfectly captured. So I'll also just take a step back to say that, our country, the challenges that we face it's considered the triple challenge of poverty, inequality, and unemployment. And it seems to be getting worse. And the World Bank actually attributes our inability to solve these problems to our slow economic growth in the country. We have that. And then we also have that our debt is becoming more expensive. So as a country, as our government, our debtors want more money to justify their investment. And there's economic perspectives on whether that is justified or not, or whether our government could negotiate much more favorable terms. And we could talk about that, but because most of our debts is denominated in rand. So it's actually, our government owes South African debtors. And so regardless of that, we spend more money on our interest on debt than we do on anything else. We spend more on interest on debt than we do on healthcare, which we are seeing the impact of that. That funding could be going towards improving the quality of the state of public healthcare in our country. So the government's response to the issues that we're facing is to undertake a path of fiscal consolidation, which to us, we see it as a really fancy way of saying austerity. This is an austere path because it proposes social cuts to social spending today, so that we can hopefully one day in the long term have fiscal sustainability tomorrow. And I think Haroon has also captured that it has been found to worsen inequality, poverty, and all of those issues in the short term. And we would like to see what happens in the long term. We also know that we've been on this path of fiscal consolidation before the pandemic. So it's been about 10 years, maybe 11 years since the government has undertaken this, and we're not really seeing the returns. We're just seeing reduced resources available to provide quality access to quality healthcare services, but economic growth hasn't really been stimulated in that way. And this approach is really the status quo in more conservative economic spaces. But if you ask human rights groups or human rights centered, foregrounded organizations, so the UN, civil society, we reject that view, because it really does mean fewer resources available to provide quality healthcare, especially to children in this country. And yeah, so that's just really the outline and the context that we find ourselves in. But I think, I'm assuming that most people here are healthcare practitioners who maybe don't navigate the budget cycle with as much detail. And even for me, someone who, as practitioners in the budget space, we know that the budget cycle is really, really confusing. So I just thought to include in the slides in my presentation, just when do certain decisions get made. I think the best place to start the cycle, it is an 18-month process, and it happens. So while we are planning the budget for next year, we are monitoring, auditing, and dealing with underspending from the year before's budget. So it's concurrent, and it's quite a complicated process, but it is one that actually does work. I'd say it starts in April, when Treasury says to government departments, these are the guidelines that we would like to approach. This is the spending guidelines for the next year. So the ones for this year for the budget speech and everything else happening next year. So then it becomes a process of back and forth between government departments and treasury, government departments and treasury, and then it is approved by October. We have what we call the medium-term budget policy statement that's being tabled, and really what it is that it adjusts the budget to account for maybe disasters that have happened this year or any adjustments that need to be made, but also to better reflect the priorities for the budget over the next few years. So it keeps going on, and then we have the budget speech, and then after that, that's when we really see opportunities for public participation, be it the parliament processes, submissions to parliament. We have those also in the MTBPS as well, but these typically get more media attention around the budget speech. And then, there's also auditing that happens throughout the year. I highlight this to say that we are a long way in our country when it comes to really creating a budget that is actually shaped by the intended beneficiary. So we don't have as many public participation mechanisms as we would like, or that would translate into a budget that actually reflects the needs of the people in the country. We're limited to public participation after the budget has been tabled and the decisions have been made. So we make recommendations and they do work. Sometimes, last year or this year, actually, we had the Western Cape Children's Commission was represented by a 17-year-old girl who was explaining the impact of the budget on children's rights. And so I do encourage everyone who's on the call to participate and engage in this, because these are hard-won freedoms. But to say that it could be better, and as civil society, we advocate for a budget process that actually at the pre-budget level, before the budget is tabled, so that we as the people of this country can actually shape the budget. So now back to healthcare funding. I think we know that our healthcare system is understaffed. There are delays in healthcare delivery and infrastructure backlogs. And while public investment in public healthcare could be a powerful way to alleviating these issues, we're seeing a downward trend in investment. So basically, we have our inflation rates, and maybe this is a skill or like an important note for some people who are new to this, is that it's important not to take the increases that are reported on at face value. So if there's an increase to healthcare or whatever it is, we should always compare it to the inflation rate of that period. And what we found is over the past few years, even before the pandemic, the investments or the increase towards healthcare funding has been increasing below inflation, which means the cost of living, the rising cost of living, has been eroding investments in healthcare. Last year, it was cut by 4.4% in real terms. And then before the pandemic, there was a real cut of 1.6% in public healthcare. Then, of course, there was a spike during the pandemic because resources were redirected to overcoming the pandemic, rightfully so. But since then, we're seeing budget cuts. So in real terms, so after accounting for inflation, the real investment is that in 2022, 2023, it has been cut by 3.6%. And then last year it was cut by 4.4%. And this year, the healthcare budget has been cut in real terms by 2.9%. So there's less money that is available to actually adequately fund staff, the healthcare system, the healthcare system. So this is a problem because the public healthcare system, as we all know, is already deeply understaffed. We know about the shortages in skilled health practitioners in order to achieve the goals or the aspirations, the policy targets in our country. And the Human Resource for Health strategy has warned that if we continue down this path, this shortfall is only going to worsen. However, we're not even inflation linked. The personnel spending towards healthcare is actually reducing with inflation. So there's been this year, there's a proposed 2.5% increase, which is a real term cut. And this means that there are going to be reduced head counts of staff. We're already seeing it, and it's likely to get worse because there's no funding available or allocated towards alleviating the understaffed nature of our public healthcare system. And we know that it's the overworked staff who are faced with the burden of it is the staff who have to provide more public healthcare services, but with fewer resources. And that really overlooks the human rights or the rights of even the healthcare practitioners, and it's a concern for us in the economic justice space. We also see this in healthcare infrastructure. So last year, healthcare infrastructure was cut by 440 million rand, and that's before accounting for inflation. This year, they've proposed a 1.2 billion rand cut, and it's 1.2 billion rand every year for the next 3 years. So there's a nominal, like at face value, disinvestment in healthcare infrastructure, even though in many parts of the country, healthcare infrastructure is really falling apart. And again, it's the staff who are keeping it together, who are expected to provide quality healthcare services with infrastructure that's not really at the state that it should be. This grant is particularly plagued by underspending. And so I will speak to the recommendations for underspending later, just in the interest of time. We're also seeing these budget cuts in HIV spending. So HIV received a budget cut, a shocking cut of 1 billion last year. And this year, next year, and the year after, they will be cutting the budget by 1.3 billion rand per year. And they say it's because it's easier or it's cheaper to get antiretroviral treatment as a country. But we've long argued that we're so far from reaching our 95, 95, 95 targets that unlike our neighboring countries, and we should be using this funding, those savings, they shouldn't be returned to Treasury, but really they should be scaling up antiretroviral treatment, but also just scaling up the healthcare system, that's a much needed way, so that as many people, especially children.
Matshidiso.
Okay, thank you. So that children can receive access to quality healthcare services, so that people can be improved antiretroviral retention in the country. The HIV/AIDS education is provided by the Department of Basic Education, but it still has health implications. And I just included this in the slides to say that for years, this has been the budget for HIV education has been cut in this country, which is very concerning considering our HIV burden. And the risk that that young people, especially young girls in marginalized communities have, like they're most at risk and they disproportionately bear that risk. However, this year, they've reversed that cut. So they allocated a 16% increase, which shows that maybe, yes, the status quo is austerity, but with, if we keep voicing out that this is really important, maybe there is some progress that can be made and some gains that can be made in the public participation processes. So to wrap this up, I'm not of the view that this is all doom and gloom, and that we should just accept things as it is, that our economy is not where it should be. So we should just sacrifice the right to healthcare. And then when things get better, we'll start having access to quality healthcare. Rather, we've advocated for ways to better position our budget, that even in times of economic downturn, we're still able to protect the right to access healthcare for children in this country. The first way to do this is through human rights impact assessments, participatory ones, as that it really creates a bridge between healthcare budgets and the constitutional obligation of the country to realize quality access to quality healthcare in the country. So we call for extending this so that whenever a decision is made, so for example, they cut the budget for HIV, it's not just that Treasury say, and Treasury recognizes, they say, oh, this will likely worsen the quality of healthcare services, but to extend that and say, okay, we recognize that it will, so what do we do then? If we're going to cut the budget, how do we maintain or even improve the quality of healthcare services in that context? So that's one way to do it. Another way to do it is by introducing gender responsive budgeting. So this is another example of one of the wins that we've made as a society, because of our call for gender responsive budgeting, Treasury has committed to introducing that in the medium-term budget speech. So I encourage everyone to keep a lookout and see whether it does actually protect the rights to healthcare access in the country. It is particularly important for healthcare because unequal gender norms have necessitated that most people who are working in public healthcare are women, and most people who are taking children and family members who are looking after family members who are feeling ill are women. The care work burden is disproportionately carried by women of this country. And so when you cut the budget and reduce the resources, it has had implications on gender inequity in the country. The last thing I'll just, because I'm running out of time, and I just want to respect the other speakers, to say that we also call on, rather than cutting budgets, we should be allocating them towards investing in training, capacity building initiatives, and consequence management to ensure that the little money that is already being allocated towards various aspects of healthcare actually gets used and used for healthcare purposes instead of being returned to government. So yeah, I think I've run out of time. I'm really sorry if I took too long, and I'm really looking forward to any questions. So yeah, I'll just stop here. So yeah, thank you.
Great. Well, thank you very much for that introduction to Economics 101. I think we're much wiser now about some of the where our money is being spent, but also where our money is being cut and how it affects children. So that's, I think, is a very useful introduction. Sorry to push you for time, but clearly we want to get the best bang for our bucks in terms of time. There will be a number of questions, I'm sure, coming up. So I didn't say that at the beginning. We've got both the chat function and the Q&A function here, but I'm suggesting we use the chat function. If you have any questions coming up as the speakers, to please raise some issues. We'll also have opportunity in the 15-minute discussion after the three speakers have presented to raise some issues. But please do feel free to raise the chat. Okay, we're going to move on. So our next speaker is Laurie Lake. Laurie may be familiar to many in the child health community. She's the communication and educational specialist at the Children's Institute at UCT. And certainly those who read the South African Child Cage know that she's played a central role in its production in recent years. She's also involved in designing and teaching many of the Children's Institute's child right courses that are directed to health professionals and allied health professionals. So she's got various other roles. She serves on the advisory committee of the PEDS department at UCT. She's on the executive of the South African Child Health Priorities Association. And she's helped raise awareness on many issues, particularly around commercial determinants of health. And this issue, which we're discussing this afternoon, has really been her influence, the impacts of austerity cuts on children's health. So, Laurie, can I ask you to please present on the issue of, so we all want to advocate for our children. How actually can we do this? Because we're desperately looking for solutions and ways to make our voices heard. Please go ahead, Laurie.
Thank you, Haroon, and it's a real pleasure to be here. So there are a number of different arguments that we can potentially draw on to advocate for greater investment in maternal and child health. The first argument is an economic argument, and that emerges out of the work led by James Heckman, who was a Nobel laureate in economics. And what he found through his research was that the rate of return to investment in human capital is greatest for investments in the earliest years of life. And that includes early in the antenatal period. These kind of investments make good economic sense. The second set of arguments is related to the science of early childhood development. And in particular, the findings that have emerged out of the field, which is entitled DOHAD, or the Developmental Origins of Health and Disease. And what they have found is that the risk of non-communicable diseases escalates or increases across the life course. But if we intervene early to limit those risks, particularly in that antenatal and postnatal period, that first 1,000 days that we're focusing on in particular in the child health community, that can change the trajectory. It improves not only outcomes and health today, but it improves health and outcomes across the life course. For example, getting nutrition right in utero and in those first years of life, preventing stunting will also reduce the burden of overweight and obesity later in life and a whole range of NCDs associated with that. What's also clear is that interventions that take place during childhood and adolescence have been found to be protective of the next generation of children. But instead, what we often do is we wait and we wait and we only screen, in a sense, when it's too late to reduce the risk in adulthood. And then we're left trying to treat adults who are living with NCDs, which is extremely costly. And what we're starting to see is our healthcare system becoming overburdened with this growing epidemic of NCDs. So if we're wanting to intervene from a scientific point of view or a medical point of view, we need to be intervening early as early and preventing rather than treating disease. Then there are a string of rights-based arguments. If we look at Section 28 of our Constitution, it recognizes that children are particularly vulnerable. They're dependent on adults for care and protection. And for this reason, children's rights to basic healthcare services are immediately realizable, unlike adults' rights of access to healthcare. Children's rights are not limited by progressive realization or having available resources in place. And this has been found by a number of child rights experts to indicate that children's health care needs should be prioritized within the broader basket of care. It's also important to pay attention to some of the very clear direction that's been issued by the UN Committee on the Rights of the Child. This includes its General Comment 19 on the public budgeting for children's services. And that indicates that states may not or should not take deliberate regressive measures in relation to children's socioeconomic rights. And that even in times of economic crisis, when resources are thinly stretched, regressive measures may only be considered after assessing all other possible options and ensuring that children are the very last to be affected, especially those in vulnerable situations. And this set of guidance from the UN committee was reiterated again by the committee in its concluding observations to the South African state earlier this year. They were very clear that children need to be protected, both from the impacts of inflation and from budget cuts in relation to social spending. So this is a very important rights-based argument that we can also draw on. And important to recognize that those international rights also carry legal weight here. There were central arguments in the Equal Education and Section 27 court case when they took the Minister of Education to court and forced the rollout of the NSNP program during COVID. And there again, they said children cannot wait. Children's needs must be prioritized. There may not be a regression of children's socioeconomic rights, even in times of crisis such as COVID. We also need to take a look at the current state of child health services. For all of you working in the child health services, you're, I'm sure, acutely aware of the ways in which the COVID-19 pandemic disrupted routine child health care, as resources were diverted from children to adult COVID care. And then what we've seen is that children's access to services has remained suboptimal despite the valiant attempts of clinicians around the country to start scaling up programs such as immunization. And that's one of the reasons that we have seen in 2023 outbreaks of measles in all 9 provinces. At the same time, many clinicians are reporting seeing children with more severe forms of disease and disability. And so this raises a concern. At the moment, what we seem to be doing is we seem to be operating in crisis mode. We're running these top-up immunization campaigns to put out fires instead of actually investing in rebuilding our child health services. And we need to be doing more rather than less to be protecting child health at a time of increased vulnerability. What's of greatest concern is what appears to be a fundamental shift in the trends in under-5 mortality in South Africa. And if you look at the red circle on the right-hand side of the diagram, you'll see that preliminary data emerging out of the Rapid Mortality Surveillance Survey run by the MRC is showing a significant increase in under-5 mortality. And that increase started to tick up even pre-COVID-19. You see a significant drop that's associated with lockdown, and then a continued increasing trend moving forward. So there's a real concern that the combined effects of austerity and the economic recession are having a profound and damaging effect on children's health, survival, and development. It's not clear how to weigh those different things up, to pin down the exact causes, to be able to say for certain that austerity is driving this. There's definitely concerns about a rise in food poverty, with 4 in 10 children now living below the food poverty line. That means they're living in households where there isn't sufficient money to even cover the basic nutritional requirements of the child, never mind any other expenses there might be, or school shoes, or clothing, or electricity, or transport. So deeply, deeply concerning that nearly half of children in our country are living in those extreme, living with those extreme levels of poverty. It's perhaps not surprising that we've therefore seen an increase, a 23% increase in the incidence of SAM between 2018 and 2022. But at the same time, of equal concern are the gaps that are emerging within the fabric of essential child health services. What we're seeing is a decline in immunization coverage. It's now down to 82.2%, down from 85.5% the previous year, way below what's needed to achieve herd immunity.
35 minutes.
Okay, we're seeing pediatric HIV treatment lagging way behind those 95 targets. School health screening, access to school health services is also being compromised. Those services are contracting. And we often talk about community health workers maybe being the solution in helping us bring services closer to home. Yet only 15% of their time is spent on maternal and child health. And then, as many of you will know from the previous issue of the Child Gauge, only 1 in 10 children with a diagnosable and treatable mental disorder is able to access treatment. So huge concerns about access to basic healthcare services. At the same time, this is an issue that is very difficult to advocate for. It's not possible to disentangle child health spending from broader line items in the health budget, such as district health services, which is a huge umbrella. We also don't seem to have national norms and standards for the staffing of child health, pediatric and neonatal services, which makes it incredibly difficult to know just how deeply you can cut a service, and at what point you cut it down to the bone and it starts to bleed out. And without those norms and standards, we have no measure to hold government accountable, to hold this process of austerity cuts in check. The third challenge is that decision-making around which services and which posts get cut is often devolved all the way down to district and facility level, and that makes it incredibly difficult for us to advocate for. We need to have a series of champions distributed across the country speaking out for children's services if we are going to be able to protect them and to act preemptively before these cuts take place. And then this raises the question of, when and how do we advocate for child health? And in my view, it's really important to be proactive to try and prevent these cuts before they kick in. And we've done a number of different things over the last 2 years. We've engaged very proactively with the UN Committee on the Rights of the Child, calling on them to reiterate and to strengthen their guidance to the South African state about protecting child health services, and that we've done successfully. We've mobilized the child health community to address this challenge through partnerships with SAPA, with COMEC, with NAPEMCO. We've also issued calls to the provincial HODs and MOCs, asking them to issue clear guidance to their provinces to ensure that the ethical principles that are going to guide the implementation of austerity cuts includes a call to safeguard child health services. And then the fourth strategy is to think about how can we build leadership for child health on the ground, in the districts, in facilities, so that we can push back against these cuts and advocate for the children in our care. But at the same time, we've also recognized that government is not really listening, that these cuts are continuing to kick in and that child health services are not being prioritized. And therefore, the next step is to really build a strong monitoring system and evidence base to track the impact of austerity, both on child health services and health outcomes. And Mandy will speak to that. So we've, reflecting back, it's been a year and a half ago since we first issued a call to action that was adopted by a whole range of organizations working in the arena of child health, including 5 of the departments of pediatrics and child health at our universities. So there's a sense of a sector that is starting to become mobilized. We're learning to use our voice, and we're going to need to do more of that. We've continued to raise these concerns in the media. So again, that's an essential part of a broader advocacy strategy. And perhaps just 2 final words. One is to recognize that children are the rock on which our nation is built. And drawing on a second quote from Frederick Douglass, who was an abolitionist in America, it is easier to build young children than it is to repair broken men. It is easier to build an effective child health service than to try and repair and rebuild a broken and fractured pediatric service. So we need to act, we need to speak out, we need to try and preempt some of the cuts and the damage that we see on the horizon. Thank you.
Great, thanks, Laurie. Right on time. I didn't have to make a call on time. I think you very concisely made the arguments why children's health and well-being does need to be prioritized. And I think you've suggested some measures what we've already done and what we might want to take on. I think that's going to be the key part of our discussion, is where do we go next after what we've already done. But just before we get into that discussion, let's introduce our last speaker, and that's Dr. Mandy Wessels. Mandy is also a pediatrician. She works in Imangeni in KZN, and she's head of the clinical unit of pediatrics there. And a lot of her work relates to monitoring and evaluation. She's got a PG DIP from UCT's Child Health and Community Pediatrics program. But I think most notably, more recently, Mandy has taken over the leadership of the Child PEP program. So she's been more than a decade worth been involved in the Child PEP program. She's been on the executive since 2018, but she now chairs the committee for the last 2 years. So a strong background in audits and monitoring. And I think that the question Mandy's going to answer is that our existing surveillance system, what are they, and can we use them to monitor the impact of these cuts so that we have a much stronger case to say what it's not just us pleading a child rights approach. We've actually got some data to show why some kind of intervention is required. So Mandy, over to you. Thank you very much.
Thank you very much, Prof. Silaji. Thank you to the two previous speakers. So exactly that. My job today is to say, well, we've heard from our first and second speaker that we can sort of predict from past bad experience and from previous experiences in the world what budget cuts will do to the state of health and children's health. We know the impact it will have, and we desperately, as child health advocates, want to ring fence the funds that serve our children. But as always, to advocate, we need to prove the effect on our children, and we need to prove that it's having an impact. It seems obvious to us on the ground, but when you want to advocate, it always starts with numbers. And so the question I'm hoping to answer today, although I'm not sure that I'm going to answer it that well, is how? How can we monitor and report the effect that the austerity measures are having on our children? And can we use any of the existing programs or systems that we already have? So the 5 that I'm going to talk about, I'm going to spend most of my time on the top 2, our DHIS or DHMIS monitoring system, and whether that can tell us really anything in this situation, and then Child PIP and how it can work, but what are some of the pitfalls of using it in a situation like this. And then I'm just going to touch one slide each on these other 3 surveillance systems that not everybody maybe uses as actively, but could be used in a situation like this. So I'm going to start with DHMIS, our district health monitoring information system. And I think what's really, really valuable about DHIS and why I've put it in this big orange block is that it is submitted at every single facility. In contrast to when I discuss Child PIP later, this is going to not just give you a snapshot of tertiary facilities or just of regional facilities or only of clinics. It's really information that is collected everywhere, and it uses the midnight stats and a lot of other measured parameters. And it really is the best tool we have for looking at overall usage. And you will have seen in the COVID pandemic, all of those PHC headcounts, OPD headcounts, bed utilization rates, of those overall numbers that we got to feel how the community was or was not using our health facilities, all came from DHIS. So it talks to the separations. So the admission data comes from when the patient separates from the system, either via death, transfer out, or discharge, and it does very good counts of the OPD head counts, even the short overnight stays and things. So those first 2 bullets, it really tells us about workload and utilization of the healthcare system. It does touch on deaths. And so as Laurie pointed out, we may see an upstroke in deaths, but it won't tell us necessarily how austerity linked with the deaths, or that, it'll be very easy for policymakers to say, well, yes, there were deaths, but there were lots of reasons why the deaths may have gone up. It wasn't necessarily because of the budget cuts. And then it collects the specific target conditions, and we know that severe acute malnutrition absolute numbers are monitored in DHIS for under 5s, as with pneumonia and diarrheal disease. And again, we may be able to extrapolate some of that information to link to our budget cuts. So the advantages of using the DHMIS system when we're trying to measure the effect of something, be it the pandemic that's just gone behind us or the current austerity measures, is that the stats are done, as I said, at all facility levels. So you're getting a not just a little snapshot here and there, but a really good feel for the system at large. It's useful because it's mandatory, and it's very much owned by and rolled out by the Department of Health themselves. So it's not dependent on champions here and there and of people voluntarily looking after the program behind the scenes. It's a funded, well looked after program. But possibly a disadvantage as well, being that it is data for the DOH, collected by the DOH, and so maybe doesn't have as much power in advocacy as we would like. And then it's helpful that these stats are collected by employed data capturers, facility information officers, clerks, whatever they're called in your provinces, and not necessarily by busy clinicians who may drop the ball when it comes to data as things get busy. And then I think one thing that I really like about the DHIS is that the data is published. The challenge being it's not published real time, it's published every 2 years through the District Health Barometer. And we know we had a short gap in those publications recently, but there is one that has just been published now. But at your own facility, you can view the data immediately if you go into your information officer's office and you can pull up the DHIS. But to look at the overview, you'll only be able to do that every 2 years. So the disadvantages, I've alluded to some of them. The stats are recorded rapidly, so the input is immediate to your facility burden and your numbers, but the overview and the published data is only available every 2 years. I think one of the advantages and why it's done so reliably is because it's nursing driven, which often is a better way for continuity of a program to be driven by operational managers in the nursing sector. And it makes submission therefore quite reliable, but it does mean that us, as if there are predominantly doctors on this chat, makes it a little bit harder for us to involve ourselves in what is being submitted. And then there isn't really place in our district health system, DHIS monitoring system, for opinion, for linking causality, or for even quality auditing. It's really a numerical database, so it will help us with absolute figures. I'm going to unpack a little bit a few indicators we may want to keep an eye on when we're monitoring the effects. And to do that, the NIDS data elements, the National Indicator Dataset, is actually available as an app on your phone, and you can then click on any section you'd like. So if you look at the EPI, down the left-hand side is all the things that will be measured: BCG first dose coverage, OPV under 1 year coverage, measles first dose coverage. But there isn't anywhere to report vaccine stockouts, broken fridges that couldn't be replaced. So again, it's going to tell us that the coverage has fallen, but it's not going to tell us why. It's not going to link the fact that the coverage is low because we couldn't get our hands on the vaccine because we had no money. We will be left to extrapolate that and make that link. So it will be difficult. We can use these indicators to an extent, but they won't be absolute proof of causality that the finances led to the decreased coverage. On that note, there used to be, 2016, I think, was the last time, a whole section in the DHIS where you actually reported the tracer medicines out of stock. So there was a whole section, and I've got a picture of it because at facility level, many of us still monitor this. Our pharmacies still submit this for our own management's interest, but it isn't published in the District Health Barometer because it's not a mandatory field in the DHIS version 2. So any tracer item out of stock, ART drug stock out, TB drug stock out, tracer medicine expected to be in bulk store. And actually, there's a whole page of them that used to be in the system would have been remarkable tools to monitor the direct effects of the austerity measures, because we could have looked at these stockouts and had a much more hard evidence that we can't buy drugs because we have no money, or we can't buy vaccines because we have no money. And then looking further at personnel, how can we measure personnel on our DHIS? Well, at the moment, the only 2 places I could find was under the PHC category, where you've got the average number of clients seen per professional nurse and the average number of clients seen per doctor per clinical workday. And obviously those numbers per person will go up as our staff numbers fall. So it will tell us about workload on our remaining practitioners when we can't fill posts. But the vacancy rate, your facility vacancy rates, are no longer put into the DHIS. Again, most facilities capture this from their HR departments, the vacancy rate and the number of posts sitting vacant or frozen. But they're not something that we'll be getting published figures on nationally very easily because they don't go into the national DHIS. So I'm going to shelve DHIS for now to say that there's some useful indicators, but not ones that are going to tell us the actual meat of the problem, and look at child PIP, which we know was developed precisely to assess the quality of child health care using death auditing tools. And it uses an extensive list of modifiable factors to guide your clinicians into thinking of the factors that led to the death of a child. The challenge being that it's limited to mortality and not morbidity. So it's, again, looking at the tip of the iceberg of the children who died, possibly related to austerity measures. And how can we do that? Is if you go to your child PIP codes, this is the version 4 codes, you've got a whole column of administrative modifiable factors at the level of the ward, the A&E, the referring facility, the clinic, and the home. And for each death, you can then say, and I've just put a few slides of these examples in the ward where you might find these go up over the next couple of months and years during these difficult times, is inadequate resus area, lack of high care beds, inadequate supply of food or milk to the ward, inadequate antibiotic supply to the ward. And I'm really wanting to just encourage today the clinicians, when you're doing your child PIP audit, stop and pause at the administrative factors of every death so that we can try and get a feel for the burden of these austerity measures on our child mortality. At the level of the A&E, basic lab investigations not available, lack of appropriate radiological services, hospital beds overcrowded, lack of access to theatre. Under the A&E, again, inadequate IV fluid supply, inadequate no pulse oximeter, antibiotic supply. So here, unlike DHIS, we've got the opportunity to code absolutely specific things that we couldn't get while there was no money and how it impacted on a death. So the link is going to be more clear using child PIP. However, the big limitations here is that, number one, it's not used in all facilities. It's hospitals only, not really clinics, who admit children. So it's not going to be every hospital in the country. The uptake varies. It's dependent on champions. And because we've just are undergoing a version 4 rollout and there's been software issues, there are entire provinces that are battling to submit CHIP data right now, while Limpopo's submitting 100%. Provinces that were on board, like Western Cape, are really struggling at the moment. And then something that's always been a struggle with child PIP is that it's not web-based. It's not real-time. It's not like the Notifiable Medical Conditions app that instantly gives you an answer or gives you a database. It's something that requires twice a year export from a facility, and then published data follows much later. And so it will be lovely to look back on the CHIP data 5 years from now and see how the austerity measures were captured, but it's not something we'll be able to use to advocate right now. And COMIC is really the only people using our data at the moment for publications. Here, there's little DOH support to make it mandatory so that we can upkeep the program. There's no financial support for child PIP. It's all fundraising by volunteers who are busy clinicians. But the one positive side of that is that there's not much meddling in the program in terms of trying to in any way hide modifiable factors. And then the last limitation I've mentioned with the tip of the iceberg, we're only looking at how the austerity measures impacted on mortality. We're not looking at quality of care with child PIP on our live patients. So the last three, I'm skipping through one slide each, and that's just to say, remember when you're reporting your patient safety incidents that you're going to be looking through your 5 whys or your fishbone diagram, whichever method you look at, whichever method you use to look at your root cause of a patient safety incident. It will be really important to try and remember to capture where finances impacted on a patient safety incident. So for example, a frequent fall from a cot because you're unable to replace those with broken sides. There's no money to replace, or there was an adverse medication event because you're using an alternative that doesn't have a favorable side effect profile, or you've got an adverse event relating to fluid overload because you didn't have a rate controller or a giving set. But it will be up to the individual clinicians to make those links. And then patient safety incidents are captured electronically in most provinces, and they're sent to head office, but they're not really published. So again, the information may stop with provincial governments and not necessarily something we can access easily when we're trying to advocate. The same with patient complaints. Patient complaints I found and have used in my career to advocate for change because they hold an enormous amount of water, and they have to be responded to and resolved within 25 days. They are also reported under the quality tab on the DHMIS, but all you're reporting on is whether they were responded to in time. The patients, however, are not going to necessarily know that the budget cut have led to their frustration. So they might just complain about the waiting time. They don't know it's because you're running on a quarter of your staff. And so again, it's going to rely on extrapolation. It's going to rely on very brave advocates in the system who have to then say, well, this patient complained because of waiting times, and the waiting times are high because of the vacancy rate, and that is high because of the frozen posts. And that's going to take a lot of links to be made by already swamped clinicians. And so the patients themselves won't be able to put that as obviously in writing, but it's certainly something that, because it's captured and responded to, we may be able to watch the complaints and use the number of complaints that go up, for example, on medications that are out of stock that they usually take, or monitoring of long-term health conditions like diabetes or waiting times, and use that in our advocacy, in our advocacy basket when we're trying to measure the effects of the austerity measures. And the last one is clinical governance. And I have only been in KZN for 10 years, and we submit quite extensive clinical governance reports every month where we are able to say we had delays and referrals because we couldn't get an ambulance, or we had a delay in a referral coming in because we couldn't access the helicopter, or we had stockouts of various things that impacted patient care. We submit these reports, they get captured somewhere, but again, they're not published. And I don't think, I don't know where they land up finally. I don't know if they land up on head office desks or where they land up with policymakers. Are they captured? Are they monitored? Are they published? And again, relying very much on the clinician to use these reports to make the link between austerity and what is going on. And I included the last three just because we've got many people on this webinar who are clinicians, and it's to say, when you're filling in these reports, when you're doing your PSI and you're doing your complaint report or your clinical governance report, in the times that we're in, just to motivate people to stop and think and try, where you do believe that the austerity measures have impacted on a negative outcome for a patient, is just to try and remember to write it down, because overburdened managers who fill these things quickly often tick them off a list and send them off their desk quickly. And I think that some of these tools are all we have at the moment to monitor what's going on. So really, I'm going to summarize.
Wrap up in the next 30 seconds.
Excellent. It's my last slide. So the way forward is that I'm not sure any of our existing tools are exactly right. You know, child PIP is the closest in terms of being able to actually code the modifiable factors that were administrative, but it's not real time enough, and it's linked only to deaths. And so I feel that if we want to be on the ball in advocating, we might need to design a specific tool that uses similar inputs as child PIP in terms of the modifiable factors, but something that can be captured real time, something that is not being driven necessarily by DOH, and that the managers themselves can sit with and not put them somewhere bigger. And then the question is, who would then drive this process? Would you be able to register it by somebody researching it from a public health space, or would we need an NGO to take it on? And so, as I did say, I'm not really answering the question. I'm showing you a lot of reasons why what we have is not perfect in monitoring what's going on, but encouraging you to use what we have and then to think about ways that we can do it more creatively. Thank you.
Thank you very much, Mandy. So I think you've met the brief very well. You've highlighted to us some of the existing surveillance tools that we may not actually think of, and perhaps suggesting how we might use them. But as you say, it's a difficult question. Do we have specific indicators that can allow us to measure the effects of austerity? No, we don't. So, folks, we've reached the 4 o'clock mark. I'm sorry that the management hasn't been as tight as I should have. I'm going to ask you to perhaps oblige us with 10 more minutes for the discussion. If you have to leave now, that will be fine. Just to alert you that we have applied for ethics points. And so that once that application comes through, we will send it through to the HPCSA. And obviously, we've got a record of everybody who's attended, and we'll use the cutoff of 4 o'clock now. But I'm going to ask your permission to perhaps go on for 10 more minutes. I've been monitoring the chat line and the Q&As. There have been a few issues raised, but there have been more comments than actually questions for the panelists. So if you want to set a question, please do so. But I've got one question for each of our panelists, and they're difficult questions, but perhaps let me raise them while you have an opportunity to raise further questions. So let me start off with Matshidiso. I think what I've learned from this is that there's many compelling reasons why children should be prioritized, and I think Laurie particularly raised those issues. But I think one of Laurie's comments that she made was the most telling for me. She says, government is not really listening. And I think that's the sense all of us have had. So how do we make governments listen? So Matshidiso, you gave us an example of the Treasury being influenced in terms of that HIV grant. Can you perhaps outline for us what are the kind of, why would sometimes Treasury respond to particular arguments? And in this field of children's health and well-being, if we had to direct our attention to Treasury, what are the kind of things Treasury does respond to? So just give us that example or other examples where Treasury has been influenced, and what can we learn from those lessons?
Thank you. So yeah, I think that's a really good question. I'm sure it'll be helpful to everyone who's on the call. I think maybe just to directly answer your question, what I have noticed to be a pattern is when we come together. And so that's why I really do encourage healthcare practitioners, even like to reach out to me so that we can all work together and have a really like research informed, but also lived experience informed and response. So when I think Treasury typically is like very, there are moments that when they do listen, maybe won't listen to the overall overhauling of the fiscal framework, which is unfortunate. But if you make points that are research and evidence-based, I think that there is an acknowledgement or recognition, also reminding Treasury of their obligations and their constitutional obligations and how, so I think they definitely listen in that way. And I think what also is a really powerful way is because, they are money people, they economics driven. So I think in Laurie's presentation, she showed the investment in children's health or like the return on investment, that's the kind of language that Treasury resonates well with. I think my answer is now just speaking to Treasury, but I think one of the highlights here is that one of the issues that we have is that the Department of Treasury or Department of Health and National Treasury are sometimes not on the same page and there's contestation with that, which is really concerning because we really want government organizations to work together, along with the Department of Basic Education, along with Parliament, so that they can better place our economy to advancing these sorts of rights. But I think that if we together all come together and work together, we set an example to Treasury and to the various departments, and they, then they respond. They're obliged to respond, and they do respond in a more across sector, intersectoral response, rather than like one department saying one thing and then the other department saying another thing. So this is all to say I really encourage like us working together and engaging moving forward, because I think that that's the best way that we can really bring these issues to Treasury's attention.
Okay, thanks a lot, Matshidiso. I had another question, but I'll save it for now. So, Laurie, your question is from comments, for example, for Russell Rensburg and your own discussion. You raised the issue of prioritization of health budgets, and you raised the point that there's no separate children's budget. So perhaps the question is, how then can we help this prioritization budget? What do we need to do? And specifically, should we be arguing for more specifically about where children's health needs compared to others? Is that approach any helpful to say rather than spending on this, should we be spending on that? And let me just give you for 15 seconds, one of the ones I was most offended with was when during fees must fall. University students during fees must fall got 47 billion rand budget for the NSFAS at that time. For me, that was a terrible, terrible decision, because at the same time, if that graph you showed from Hickman as your first slide, if you had invested in early childhood development, the returns are much higher, and the number you would need at that stage was 10 billion rand per year. Instead, we gave it to university students. So it's the question of budgets and prioritizing budgets and affecting those decisions. But the difficult question for you is, are there ways we can influence budgets, recognizing that there's many levels to these budgets? And do we have to be really making the case that if you did this 10 million or 10 billion for children, you could do that instead of doing this, that? Or is there a different way of approaching this?
So I think the challenge in relation to child health budgets or investment in child health is that decision or those kind of trade-offs are not being made by Treasury. They're being made at a provincial level. So there's a question around what are the priorities? How do we engage and influence the thinking of the HODs, the MECs in each one of our provinces? How do we help them make the connections between those investments in early childhood and reducing the burden of NCDs? And how do we help them see that we're not speaking as pediatricians versus obs and gynae versus surgery. It's not a professional turf war that we're talking about. We're talking about children who have a prior claim in terms of the rights framework, and who are absolutely essential if we're going to build a healthier society. And I think the challenge is that many of the people who are in those decision-making posts are not necessarily rooted and grounded in the science of child health. So there's a lot of advocacy I think we need to be doing at a provincial level and then all the way down to facility level. But if we're going to look at the best win that we could hope for is for those provincial departments of health to issue guidance when they send out the kind of criteria that are defining what gets cut and how, that children are prioritized within that decision-making framework. That means we're looking at decision-making at a provincial level across the whole province, rather than trying to advocate facility by facility, district by district. You're on mute, I think.
And have you got some ideas as child advocates who often have this webinar from a clinical space, some perhaps from a child public health space, how we can more actively be engaging with these provincial and district budgets? What's needed from us?
I think we need to be engaging with the leadership and management, not just in relation to the budget process. I've certainly attended the budget vote in the Western Cape Parliament, and as Chidi was saying, by that stage the decision has already been made. So you may have the opportunity to raise the issue, but that's not the forum to shift the decision making. So we need, in combination with this sort of awareness raising in the media and in those public spaces, we need a lot of quiet diplomacy and education of those key decision makers. And all of us can play a role in those conversations.
All right. So,
and one last thought. So one last thought is also that there are two other surveillance systems, for want of a better word, and they're kind of led by the Treatment Action Campaign and Section 27. And that includes the Stop Stockouts campaign and the Richidze campaign, where community members are tracking stockouts of essential medicines, staff shortages, but with a primary focus on HIV and the adult population. If we could use those tools and make sure that children and child health and maternal and child health are prioritized in those tools, that would be another form of driving accountability at a local level.
Thanks, Laurie. Okay, so Mandy, your question. Michelle Zuckerman has raised the issue about what about us looking at ourselves? So this isn't quite, it's about quality assurance, which was part of the arena you covered. It's about, can we be doing more within, as health workers, one, to change our own practices to find ways of reducing budget. I suppose the most extreme example, we know a lot of these budgets are 1.1 billion of the I think the figure Matshidiso gave was the actual budget for salaries is 1.71 billion, but at least 1 billion is the increases we get every year. So here's 2 points for you, Mandy. The really political one is, should health workers be happy with the salaries they got and not be demanding and putting the health budget into jeopardy, because Treasury doesn't want to pay those additional expenses. But more importantly, can we be doing things ourselves in our ordinary practice that might assist in reducing these budget excesses?
Thank you,
Questions,
Prof, for
Mandy?
those difficult questions. I think
Yeah.
I'll start with the second one because the first one is very difficult to answer. I think it's a very fair question, and I think that all of us who are in managerial roles in the Department of Health right now have a duty to sit down with our teams. I've certainly done it recently to say, where can we do better? Where can we stop doing unnecessary investigations? Do we need stricter criteria for who gets CT scans? Do we need to look at more restrictive blood transfusion practices? Places where we know are our big expenditure, something like the IV form of caffeine versus the much cheaper caffeine powder that we can get, but it's off code. Can we not be motivating for that? It's a 300 times difference for a nursery my size that adds up. And I think that's a very good question. Every single one of us sitting with austerity measures, apart from advocating out there to the powers that be, we should also be looking at our own guidelines and policies within our units to make sure that we're not in any way embarking on wasteful expenditure. And we hope that would then mean there's more for what we really need and the patients who really need it and the posts that really need to be filled. So yes, I think so. I actually don't know how to answer the question on the increases. I mean, I think the overtime issue is the first one that needs to be dealt with as a whole separate thing. But I don't think that cutting personnel and pushing people out of our sector into the private sector or overseas is an answer to a long-term problem either. So we do need to look after our staff at the same time.
All right. Thank you very much, Mandy. So panelists, thank you very much for your time. There have been certain more comments and questions that have come through, but I'm going to stay to the promise that we wouldn't exceed by 10 minutes if I haven't kept that promise. So perhaps let me then summarize by saying, I think for me, what I've learned in this webinar is I'm certainly much wiser about some of the money and the cost involved in austerity. What are the cuts, the size of the cost, and in which areas? So that, thanks for that, Matshidiso. I think, Laurie, you provided us an excellent framework of the arguments we can be using to make the case why children are special in this situation, and also offered us some ideas about where our actions could be directed. And then, Mandy, you had the difficult task of saying, could we use our current surveillance systems to more effectively be advocating for children? And even though your answer was they're difficult and they don't give you immediate answers, I think even if not specifically for austerity, using it as advocacy tools, any of those would be very helpful. So at the end, I'm still not quite clear what I'm going to go do differently tomorrow, but I recognize that that advocacy efforts are required, and that we need to be continually arguing among ourselves what might work, what might not work. There's no single answer. It's certainly, like most advocacy efforts, requires a lot of work, whether we're trying to convince our provincial managers or district managers, or whether we directing our efforts to Treasury itself. But I think what we certainly can say at the end of this webinar, we've learned a lot. It's been excellent. And so I thank all our panelists for their time. And I do thank the over 120 people who were interested in attending this session. I thought austerity we'd be lucky to get 30. I'm delighted that so many of us, so many of you were willing to come and hear about this. So thank you very much, everybody. Appreciate your being here, and look forward to you joining us at the next Child Priorities Association webinar in a month's time. Bye.